everyone. Thank you so much for coming to the talk today. I'm going to be talking a little bit about some research that we've completed looking into neurodevelopmental presentations in children and young people with BBS. I'm Gabby Blumer, I'm a clinical psychologist, and the research was completed with my colleagues Emma McGibbon, over here, and Jo Moss. The research was completed at the University of Surrey in collaboration with Great Ormond Street Hospital and with a lot of support from BBS UK as well. I'd also just like to take the opportunity to thank all the children, young people and families who took part because, without your participation, this wouldn't have been possible. Okay, so just a little bit about how we came to work with people with BBS. At the time of starting the project, there were around 560 people known to services who were living with BBS in the UK, and as we heard just before lunch, that's gone up quite a lot since then. Before training, I worked in a neurodisability service with Emma, and one of the clinics that we worked in was the paediatric BBS clinic at Gosh. So there's such a huge variability in the features of BBS that we see and how affected people are by different areas, including the associated visual impairments and learning differences. And whilst support is often centred around children's medical needs, families have told us that the neurodevelopmental differences are an important part of the presentation, which we were hoping to explore in more detail. Okay, so to start with, what do we mean when we're talking about neurodevelopmental profiles? So neurodevelopment is a term referring to the development of pathways in the brain that affect differences in people's functioning. So for example, cognition, communication, social, sensory, emotional, and so on, all those different presentations. And if somebody has difficulties in one of these areas, they might be diagnosed with a neurodevelopmental disorder. And some common diagnoses include autism spectrum condition or autism, ADHD, and intellectual or learning disability. Neurodevelopmental differences usually present during stages of child development, but continue into adulthood and throughout the lifetime. And looking at the neurodevelopmental profile of BBS refers to investigating whether there are patterns that might be seen across lots of people with BBS. And this includes areas of strength as well as any areas of difficulty where some extra support might be helpful. Okay, so we know that there are some neurodevelopmental differences which are more likely to be present if somebody has BBS, but there hasn't been very much research done so far. So intellectual disabilities or learning disabilities are common in people with BBS. This affects the way that somebody learns, remembers, or applies information. It's important to note that learning disabilities are different for everyone and no two people look the same. Some people with a learning disability might need very little support. They might live independently and just need some help to complete tasks at work, for example, or complex forms, whereas some people will need help in lots of different areas of their life, like looking after themselves, cooking, and going out. So previous research has also shown that people with BBS are more likely to experience differences in their social communication. And this refers to successfully interacting with others in a typical manner that follows those kind of unwritten rules in different environments and the social norms. It refers to both verbal and non-verbal interaction. And these social communication differences are often seen in autism. And people with BBS are more likely to be diagnosed with autism spectrum condition and are more likely to show behaviours similar to those seen in autism, even if they don't have a diagnosis. So for our research, we looked at cognitive, social, behavioural and emotional profiles of children and young people with BBS, which I appreciate is not very catchy and is a bit of a mouthful. And the research consisted of two separate but overlapping studies. The first one looked at learning disability, which includes profiles of cognitive and adaptive behaviour. And the second took a broader approach with a larger number of participants, using questionnaires to look at social, emotional and behavioural aspects. Okay, so there is a little bit of research that was pre-existing and I'll give a quick overview of what had been done previously. Okay, so the diagnostic criteria published by Beals and colleagues lists learning disabilities as one of the primary diagnostic features of BBS. And this followed a large cohort survey of families describing different features. Some other research studies and surveys term the criteria learning difficulty or developmental delay, and these actually refer to slightly different things to a learning disability. So although differences in learning are one of the primary diagnostic features of BBS, the terminology across research is variable and a wide range in abilities have been reported. So in some recent case studies, a 2022 write-up spoke about 3 siblings who all met diagnostic criteria for a learning disability but had very varying levels of need. And a 2023 case study spoke about an 8-year-old girl who was doing well in mainstream school and presented with average learning abilities. So a really big range there. So for our research, we followed the formal learning disability diagnostic criteria, which consists of the 3 areas on the screen there, which must all be present to meet criteria, and I'll talk through now. So firstly, significant difficulties with intellectual functioning, which refers to our thinking abilities. And this is measured using a standardized assessment consisting of lots of questions and puzzles to generate an IQ score. And a significant difficulty is usually demonstrated by an IQ score of approximately below 70. This assessment also gives us a chance to explore strengths and weaknesses. For example, somebody might have stronger verbal than non-verbal skills or vice versa, so that we can make recommendations about what might be helpful for the young person. Secondly, significant difficulties with adaptive behaviour, which refers to our abilities to complete those everyday tasks. And this is measured through a standardised interview. And again, a significant difficulty is usually demonstrated by a score of approximately below 70 on this measure. And finally, both of these difficulties must present during childhood. Okay, this is a very complicated slide, but bear with me and I'll talk through it. So focusing on these areas of intellectual abilities and adaptive behaviour, there are 4 previous empirical studies looking at these areas in people with BBS. So on the screen, there's a graph to show what we call a normal distribution curve. It's a symmetrical curve shaped like a bell. And this refers to how assessments are designed to compare performance on various tasks across the population by age. In the assessments we're speaking about today, the average score within the population is 100, with a standard deviation of 15 points. Which basically means that a majority of people score within 15 points in either direction of 100 on these measures. So approximately 68% of people score in that range between 85 to 115, and approximately 95% of people between 70 and 130. When we talk about a significant impairment, as referred to in the diagnostic criteria for a learning disability, this refers to scores below 2 standard deviations from the mean, or below 70, circled on the screen, on the measures I'm talking about today. So previously, Brinkman and colleagues assessed 42 people with BBS, aged 2 to 61, in the US, and found an average IQ of 75 on assessments. Kerr and colleagues was a more recent investigation in Helsinki, with 24 people with BBS aged from 6 to 38. They found average IQ 1.5 standard deviations below, which would be around the 77 mark, and that adaptive functioning, so those everyday abilities, was lower than intellectual functioning. Questionnaires highlighted social communication differences and some difficulties with behavioural regulation and mental health. Barnett and colleagues completed the first study with children specifically and highlighted that there was an unmet need for this population. And Kiefer and colleagues very recently looked at early adaptive skills in children from 0 to 5 with BBS and had a large sample of 101 children. They found that children with BBS demonstrated significant delays in their early adaptive skills and were delayed in meeting their developmental milestones, and that these delays increased in significance as children got older, suggesting that the gap between children with BBS and their peers might widen over time during those very early stages of their development. So that was a very whistle-stop tour of some existing studies, but the references will all be at the end for anybody interested in more detail. Okay. Thinking a little bit more about why further research is needed in this area, I'll skip over this in the interest of time, but research in this area is limited, and we know it's an area of importance to families of children with BBS. This kind of research provides us with a better understanding of strengths and support needs, and provides information for families, teachers, clinicians and other professionals. Information can be used to support education, health and care plan or EHCP applications, and to develop resources like the newly released resources that have come out today. Okay, so for study 1, which was the study looking at learning disability in BBS, 21 children and young people attended GOSH with a parent or caregiver to see Emma and either myself or the assistant psychologist. Informed consent was gained from the parent or caregiver, and assent was gained from the child where possible, using simplified symbol information sheets. With one clinician, the child completed a cognitive assessment of intellectual functioning, which was either the Wechsler Intelligence Scale for Children, which we call the WISC-5, the Wechsler Preschool and Primary Scale of Intelligence, we call the WIPSI-4, or the Bailey-3 for children at an earlier developmental level. And at the same time, the accompanying caregiver met with the other clinician to complete the Vineland Adaptive Behaviour Scales, which is an interview measure of adaptive functioning, as well as providing a developmental history and background information. Just a quick note about completing these assessments for children and young people with BBS. Assessments were administered by clinicians familiar with testing children with visual impairments, and clinical judgment was used to consider whether to administer subtests that were reliant on visual materials or not. So feedback from assessment was provided on the day, and a report with recommendations and signposting within 4 weeks. And for the second study, 99 pairs of children and parents or caregivers took part, which included 56 children and young people with BBS and 45 non-syndromic autistic children and young people, which means children with autism without a broader genetic syndrome. And parents or caregivers completed questionnaires either at GOSH or online, and recruitment was done through BBS UK, BBS International, social media, and the Autism Research Centre, which is based at the University of Cambridge. So questionnaires used consisted of a measure of traits associated with autism called the Social Responsiveness Scale, or the SRS-2, a measure of emotional and behavioural difficulties called the Child Behaviour Checklist, or CBCL, a measure of health-related quality of life called the PEDS-QOL, and a measure of family health-related quality of life called the PEDS-QOL Family Impact. Again, a bit of a mouthful. Okay, so moving on to the results, and speaking about learning disability first. On the screen, there's an image of 21 stick figures to represent our participants, and 9 of them are coloured green. This represents that 9 out of the 21 participants met criteria for a diagnosis of a learning disability, which is about 43%. None of these children previously had access to an assessment or had a diagnosis, and 2 of them were in mainstream schools with no EHCP and no additional support or differentiated work. Most of the participants who met criteria for a learning disability fell within the mild to moderate learning disability ranges, and the 9 participants were aged between 6 and 12 with an average of 9, and consisted of 2 boys and 7 girls. Participants were from a range of ethnic backgrounds. Of the 21, 6 were reported to have received an autism diagnosis previously, and 7 were awaiting an assessment or recommended one as part of this study. Rates of visual impairment were similar across those who did and did not have a learning disability, but hyperphagia was much more likely to be reported by parents of participants who did also have a learning disability. And I'm going to break down learning disability to look at the intellectual and adaptive functioning separately. So considering intellectual functioning, on the Wechsler scales, average intellectual functioning was shifted approximately 2 standard deviations from the mean of 100, which is particularly notable because that 2 standard deviations below, or a standardised score of 70, is the approximate cutoff for the learning disability diagnosis. There was significant variation between participants in line with what we see in clinic. So cognitively, 2 participants scored in the average range, and there's a scatter graph on the screen which shows scores varying from 40 to 100 to demonstrate the variation. Whilst over half of our BBS participants did not meet criteria for a learning disability diagnosis, for most people, performance still fell significantly below the age-expected range, which suggests that learning is an area of need for a majority of children and young people with BBS. Some relative strengths and weaknesses were identified. The graph on the screen shows scores across cognitive and adaptive domains among participants who did not have a learning disability. So among participants whose cognition was higher, there remained a relative processing speed weakness, the score that's slightly lower than the others. Processing speed refers to the speed at which the brain takes in, understands and responds to information. It's important to think about this in the context of adaptations at school, such as allowing extra time on exams for people who need it, and things like that. In addition, some specific areas of relative strength were identified. Highest average scores were on measures of non-verbal abilities. These subtests were all reliant on visual materials like puzzles and pictures, which suggests that children with BBS might benefit from visual materials to support their learning when it's accessible to the individual in the context of any visual impairment needs. Okay, how am I doing? Okay, so moving on to think about adaptive behaviour abilities, so these practical everyday skills that we use to function independently. In terms of adaptive abilities, scores were similar to intellectual functioning, about 2 standard deviations below the mean. One of the previous papers I talked about by Kiefer and colleagues looked at adaptive behaviour in children aged 0 to 5 and found average scores ranging from 72 to 79. Ours fell from 69 to 72, which is consistent with their finding that the gap widened over age. And there are lots of reasons that children with BBS might diverge further from the typically developing population with age in terms of adaptive functioning. So our everyday skills like looking after ourselves, developing social abilities, it covers lots of different areas. These reasons can include health, increasing demands as we work through the school system, and also the onset of visual impairment, as in children with visual impairment who don't have BBS, we tend to see lower adaptive abilities than cognitive abilities. Okay, take a bit of a breather and move on to the questionnaire studies, questionnaire scores from study 2. So firstly, the SRS2, this is the parent-rated measure of social communication abilities. And there's a line graph on the screen which shows average results of the BBS group on the subscales of this questionnaire. On this measure, higher scores show more traits associated with autism, and scores above 60 are considered clinically significant. So in terms of total score, 20% of children and young people with BBS were rated as showing social communication skills within normal limits, whereas 80% were rated within the clinical range, including 50% in the highest range. This suggests that further assessment to consider autism might be helpful for a lot of children and young people with BBS. As expected, almost all children and young people in the autism group scored within clinical ranges, and average scores were 5 to 10 points lower in the BBS group than the autism group, suggesting slightly lower levels of difficulty across all these different areas of social functioning, though difficulties were still rated as clinically significant. Behavioural and emotional well-being was rated using the CBCL. Overall ratings of emotional and behavioural difficulties in children and young people with BBS was high, with 50% of children scoring in the clinically significant range and 24% in the borderline range. And scores in the present sample were notably higher than in previous research, but used a much larger sample. Overall rates were similar to those reported by parents and caregivers of autistic children and young people, which was notable as high rates of emotional and behavioural difficulties have been well documented in this group and have a significant impact on the quality of life of children and families. In the autism group, there was no significant difference between internalising and externalising difficulties, but in the BBS group, rates of internalising problems, similar to difficulties often seen in anxiety or depression, were significantly higher than externalising problems, similar to difficulties with disruptive behaviour. And we felt like this was in line with what we hear in clinic from families as well, that those more disruptive behaviours don't tend to be as much of a difficulty in the BBS population. Interestingly, scores on the social problems subscale were similar across both groups, which further highlighted the social needs of children and young people with BBS. Okay. How am I doing? I'm going to skip through this one a little bit, but there's two graphs on the screen showing scores on different subscales on questionnaire measures of health-related quality of life. Scores of children with BBS are the blue lines, and the autism group was the black lines, and I'll go through the key findings verbally. The graph on the left is parent ratings of their child's quality of life, and the graph on the right is parent ratings of the family's quality of life. And scores are out of 100, with higher scores representing higher ratings of quality of life. So on the left, both the BBS and autism groups reported reduced health-related quality of life compared to UK norms, but the specific areas of difficulty identified differ between the groups. So in the BBS group, quality of life was rated as being more impacted by physical functioning, which is likely due to the physical difficulties that can be related to the syndrome, whereas in the autism group, quality of life was more impacted by emotional functioning, highlighting the needs in this area of that group. Both groups' quality of life was significantly impacted by their social functioning, further highlighting those social challenges. So family health-related quality of life was was rated as being lower for families of autistic children compared to families of children with BBS. And the family relationships within the BBS group were rated as a relative area of strength, suggesting this might act as a protective factor for health-related quality of life for families. Looking at the relationships between questionnaires, factors such as social, emotional, and behavioural difficulties were significantly related to both child and family health-related quality of life. And this was seen more so in the BBS group. And these psychosocial challenges were more influential on quality of life than physical difficulties like visual impairment and hyperphagia reported by parents. This is in line with previous research showing that behavioural and emotional challenges strongly affect the well-being of families of autistic children, and suggest this might also be the case for families of children with BBS. As always in research, there are several important limitations to consider. Firstly, thinking about limitations to the IQ assessment due to other variables. For example, factors such as visual impairment, anxiety, social communication, and motor difficulties can all impact testing, but this was carefully considered and formulated within assessments to mitigate this in the research. Whilst the sample size was relatively large compared to other studies in this area, it remains small, which could impact statistical analysis. And uptake of participation in the study was high. It's likely that if the research was able to continue, sample sizes could be increased. The use of questionnaires allowed us to reach a large number of families, but introduces an element of bias, and our study utilised parent report, meaning that it didn't capture the voices and opinions of the young people. There's some ongoing or coming up towards the close of some similar research in Birmingham using self-report questionnaires with Jane, who's hiding, which will help capture the voices of the individual in this field as well as families. There's several discussions about benefits and drawbacks of neurodevelopmental diagnoses, although currently within services in the UK, we know that these diagnoses are often necessary in order to be able to access support for services. Okay, what does this mean for people with BBS? So the results of this research highlight the need for routine developmental assessment of children with BBS. This would consider several factors, including learning, neurodevelopmental screening, behaviour, emotional well-being. It would support with identifying any learning needs and ensuring that appropriate support is in place, as well as to monitor the impact of visual impairment on development throughout childhood. Currently in the UK, there's no routinely available public assessment service for children and young people with BBS. A pilot service on the NHS was trialled, and results from the current study suggest that this would be beneficial for children and young people, and would support families in guiding decisions about education and day-to-day support needs. It would be vital that these assessments are conducted by clinicians with experience of adapting assessments for children with visual impairments and with knowledge of genetic syndromes, and that early intervention therapeutic services would be helpful for children to access in the community. Future research needs have been identified, including exploring factors that impact quality of life, and I know there's some research about to be started in that area as well, and the relationship between vision and adaptive functioning in children with BBS. So just to finish with, how is this important for parents? One thing important to consider is diagnostic overshadowing, which is a term used in healthcare and psychology to describe a situation where a person's existing diagnosis, such as BBS, means that other important health issues or difficulties can be overlooked or misunderstood because the focus is always on the syndrome alone. For example, if a child has BBS, healthcare professionals or teachers could mistakenly assume that a new behaviour or presentation is simply part of that condition without investigating further for potential causes. And this can lead to misdiagnoses and delayed support, and means that asking those questions and raising those concerns as they come up is really important. So if your child is experiencing any difficulties like those that we've spoken about today, and is not receiving appropriate support, then an assessment to understand their neurodevelopmental profile might be indicated. And if you have any concerns, the best people to speak with about this would be the SENCO at school, the psychologist in the BBS clinic, or your GP. Okay. And the papers outlining the research I've spoken about today will hopefully be published shortly with some more detail in them. Thank you so much, everyone, for listening, and Emma and I will both be around during the break if anybody has any questions. I've gone right up to 29.5 minutes of my 30 minutes, so I will leave you all there for your tea break. Thank you. Thank you.